As I was putting together this talk, I started to kind of realize it was evolving into a sort of workman's compensation talk. I see a fair amount of workman's compensation, and it is the challenge with return to work. When people come in and they are not on a workman's compensation claim, it's generally pretty easy to get them back to work. They're usually asking me to go back, and I'm usually the one putting on the brakes. And so it's a little less challenging in that scenario. And so I kind of, as this talk evolved, I realized, well, we'll just go ahead and go all in and talk about workman's compensation and how I like to handle repetitive overuse in workman's compensation. Just a little housekeeping. I do have a disclosure. I have to admit that I was a little surprised that we put the most important talk of the day first. Usually you want to keep that for later, but whatever. I'll talk a little bit about some terminology, just so we're all on the same page. We're going to go through neuropathy that we see with repetitive overuse, tendonitis, tendonosis, and we'll try and kind of really distinguish between those. And then a little bit about synovitis and arthritis and how that plays into things. I find that with handling repetitive overuse and return to work and workman's compensation, knowing the rules of the workman's compensation system has been hugely helpful. And I don't think that you have to know every little detail, but to kind of know the general rules and how it applies to hand injuries, I think can be very helpful as you're treating your patients. Then I want to go through really what I wanted to say about this is the portion kind of down in here about how I approach a visit with a patient and the things that I like to kind of touch on when I'm talking with somebody about their injury, their return to work, and how I try to kind of get them involved in their own health care. And then we'll go through a couple of other things. But we're going to start with just some terminology here. Tendonitis, for me, is inflammation around a tendon. So when I talk about tendonitis, as we talk about this, it's inflammation around a tendon. It's that it's kind of this wispy tissue. You can see it. It's there. It's and it can cause a lot of pain for people. It can cause a lot of trouble, and that's different than tendinosis. Tendinosis, in my mind, is an unhealthy tendon. A tendon that is actually intrinsically unhealthy. There's maybe some tearing in the tendon. The tendon is not essentially whole. Synovitis, that inflammation in the joint, okay, that synovial lining in the joint that's hypertrophied and causing pain. Whereas arthritis, for me, this is not how it necessarily works out in workman's compensation, but for me, arthritis is the breakdown of cartilage, right? So you're getting breakdown of cartilage, you're getting maybe some inflammation secondary to that breakdown, but you are having some form of breakdown of the joint. And then neuropathy, obviously, is compromise in different forms of the nerve. The ones that I see, and particularly the ones that I see with regards to workplace issues, are typically compressive neuropathies. So we're going to start off with the controversial topic, carpal tunnel syndrome. Carpal tunnel syndrome, just very briefly, I think most of us have an idea as to what it is. It's compression of the median nerve as it crosses through the carpal canal, right across the wrist. The median nerve runs with a group of tendons, and there's lots of reasons why you can get carpal tunnel syndrome, I think, and none of them are particularly well proven. And so we all kind of have a general idea as to what we think causes carpal tunnel. The truth is, we don't know for sure. There's too much pressure on the nerve for some reason, and it could be that you have some tendonitis around the tendons, or you have the transverse carpal ligament that's gotten thick over time. You could have fluid shifts. There's all sorts of things that potentially could cause carpal tunnel, and not a whole lot of data, believe it or not, on exactly the causes of carpal tunnel. It's pretty difficult to even measure pressures in the carpal tunnel. And so when you can't do some of the simple things, some of the basic science, like measuring pressures in there, it's actually difficult to really find out exactly what the causes are. So before I jump too far ahead, for you guys, when you're seeing somebody with carpal tunnel, to help speed things along for that individual for their workplace injury claim. The things that would really help for me is if you started them with a splinting program, nighttime splinting, and if you keep them working. And so if you can start somebody with a nighttime splint and get that going before I even see them, that actually speeds things up for them in the end. They can use that at night, really encourage them to do it. So it's, I frequently will see people who have a splint and don't ever use it. And it's important, I think, when you hand it to them to really encourage them to actually use it. And we'll go a little bit more into this, but some people will come in and say, oh, it didn't help, or it actually made it worse. And I think kind of a couple words from you as you're handing it to them and say, I expect that this will actually give you some symptom relief. It may not take everything away, but it should really help a little bit, and maybe a lot. That can go a long way to getting buy-in for them to actually use it. And then, if you're up for it, order a nerve test. If they come to me with a nerve test, I can typically get somebody who has real carpal tunnel syndrome turned around just within a number of weeks. And so it's generally, if I've got these things already done before they get to me, I can help these people get back pretty quickly. And then, obviously, setting expectations. We'll talk a lot more about this, but setting expectations from the beginning. Keep them working. Make sure that they understand that they're going to be expected to work through this. And around the time of surgery, if they need surgery, I will manage the kind of return to work in that. But for people who come to me off work for something like carpal tunnel, or really almost anything else, if they come to me off work, it's so much harder to kind of get them back or to manage their expectations. So whenever possible, try and keep them working. So this study, and it's a slightly older study, it's a little over a decade old, but it really shows how all over the board we are with something as seemingly straightforward as carpal tunnel. Return to work in this study was somewhere between 1 day and 3 months. And the strongest predictor really was, and this is around the time of surgery, the strongest predictor was the surgeon's expectations, essentially, what they told people to expect for their return. And there are a couple of other things that factor in, but this really goes to show how little we know about carpal tunnel and how we can't even really make up our own minds about what we kind of want to do with carpal tunnel. Somewhere between 1 day and 3 months. Carpal tunnel syndrome in the workplace has a huge economic burden on the worker. And so I'm harping a little bit on carpal tunnel. I'm going to kind of keep talking about carpal tunnel as an example kind of through the talk. We'll talk about some other things, obviously, but carpal tunnel syndrome is kind of a staggeringly expensive proposition for a worker. It turns out that relative to fractures and even dermatitis, carpal tunnel is hugely expensive. So I don't expect you to really know exactly what all this says, but you can see that the problem and the loss in earnings goes on for years after somebody has a carpal tunnel claim. And people actually have more time off for carpal tunnel oftentimes than for a broken bone. And obviously there's a lot that goes into this. This data has holes in it, but the point is really how staggeringly expensive it is to have something as straightforward as carpal tunnel as a workplace claim. And so we clearly don't do a very good job managing this because it's a largely fixable problem for people and can, I think, be fixed pretty quickly in general. So there are a lot of people who come in and feel as though their workplace has caused their carpal tunnel. And I used to spend a lot more time kind of pushing back against that than I do now. And I kind of take people at their word as much as I can at this point. But our data suggests that things like heavy, repetitive gripping and lifting activities, high impact vibrations are really the only things that would cause carpal tunnel in the workplace. So jackhammering, for example. Typing doesn't, as far as we know. Again, we have not great data about this, but everything that we have says that typing, office work, those sorts of things really doesn't cause carpal tunnel. So we'll kind of jump back and forth on a couple things, but there's other neuropathies in the upper extremity. Carpal tunnel is not the only one, but carpal tunnel is probably by far the most common that we'll see in the workplace, so for a workplace claim. The other neuropathies, cubital tunnel syndrome, probably a lot less common in the workplace. Maybe it could be an ergonomics problem, so somebody who's putting their arms, their elbows down onto a chair all the time, or positioning in a weird position. But for the most part, we don't see this as a kind of significant workplace issue. That is, cubital tunnel is a common problem. It's just not something that people come in and kind of feel as though their work has caused. At the wrist, so cubital tunnel is at the elbow. At the wrist, ulnar nerve problems, radial nerve problems are actually not all that common. They happen up farther in the arm, they can happen, but they do present down in the hand and wrist. And so it's something that you'll see in people coming in to complain about their hand and wrist, radial nerve and ulnar nerve problems. But generally, this is one that I will kind of push back and say, tell me how your work actually caused this. Describe that to me. And I think that's a fair question for people, because you really do want to help people to understand maybe that their work didn't cause all of this. And I think it's important in general to educate people that, for the most part, overuse injuries of the upper extremity are multifactorial. It's not 100% due to your job. I have yet to meet somebody who only uses their hands at work. So, moving on, tendonitis. Tendonitis is actually, I really like it when people come in with tendonitis because it's fixable, right? So this is a problem that we can fix. And there's different ways that we might go about trying to fix it. And for you guys, for most of you or many of you, it'll be something like a splint. So activity modification, a little bit of education about activity modification and a splint to kind of reinforce that or protect them. And then for maybe a few of you out there who want to be a little bit more aggressive, a steroid injection. Steroid injections for tendonitis can be great, right? So they can even be curative in a lot of cases. And you need to know how and when to do the injections. And I think, I'm not going to go too much into that now, but if you guys want to corner me over in the hands-on stuff, I can take you through some injection stuff. But these are more easily fixed. They are something that I think you can give people a lot of hope and tell them, this is going to get better. It's okay to continue working, but we want to have you protected with the splint, or we want you to work a little bit of light duty for a short period of time to give you a chance to recover. Something along those lines. Again, still important to try and continue working through this. As soon as you start taking somebody off work for a tendonitis, it gets amazingly hard to kind of reverse that. It adds a lot of cost and time, and while it may actually be helpful for them to have a little bit less pain a little bit quicker, I think that you can really manage that pain and manage their work at the same time. So, a couple of really common tendonitis problems that you're going to see in people who are coming in with this sort of complaint. Decurvain tenosynovitis. So right at the area of the radial styloid, about a centimeter proximal to the radial styloid, and you can feel it on your own wrist, is where that point of maximal tenderness is going to be. And you're going to have a positive Finkelstein's test. Again, we'll talk about this later. Usually it's pretty straightforward. When we can talk about all the physical exam findings later, but you will, this is not a hard diagnosis to make, and people get better from this. Right? Splint, maybe an injection, and occasionally surgery. Sometimes those splints and injections don't do the job, but it's a solvable problem, and the surgery is not a major to-do. Intersection syndrome is just a little proximal to that. Similar problem, same idea for treatment, all the same steps. But again, keep them working, educate them about what the problem is, but keep them working, help them to understand that this is a one way or another, it's a fixable problem. That gives people a lot of hope. Trigger finger. Super common, obviously. You guys see a ton of these. Trigger finger is one that probably does have some workplace cause in a lot of people. The problem is just some tendonitis, that extra tissue, that extra swelling tissue around the tendon, and as it passes through that size-matched tunnel right in the distal palm, it can hurt like crazy. It can lock, it can catch. Do remember that trigger fingers don't always lock up, right? So it can just be pain and still be a trigger finger. It's the same entity. It just hasn't gotten bad enough that it's causing people to actually feel like it's catching. So trigger fingers present in a whole host of different ways. Sometimes it's a kind of a feeling of stiffness and no pain. Sometimes it's people come in and say, my hand feels swollen, and you look at it and you say, no, it's not swollen. Some people will have multiple fingers that are bothering them, but it really is just one finger that's causing the whole deal. So be aware that trigger finger is super common and can present a lot of different ways, but it's the same problem, just different gradations. So for fingers, I don't love splints for trigger fingers just because they can make people stiff, and they actually do pretty significantly affect hand function. Some education, activity modification, and then either an oral steroid can sometimes be helpful, or an injection. And the injections are pretty safe to do. Again, we can talk about more of that. I think I feel my afternoon physical exam stuff evolving here. I think it's going to be an injection talk, but we'll see. Injections into this area are very straightforward, not a big deal, and can really, really be helpful for people. I tell them, within about 5 days you're going to feel better, and pretty much 100% of the time, or close to it, they feel better. Whether it cures the problem or not, maybe not, but they're going to feel better to some degree. And then maybe less common, you can get tendonitis around the rest of the extensors or around the flexors as they run through the carpal tunnel. And so the extensor compartments, this is basically another diagram of the extensor compartments. The extensor compartments, the most common one that we'll see tendonitis is the fourth right here. This is the bigger one where a lot of the extensor tendons run through. But the first is over here, that's Decker veins. Intersections right up here. You can get it in the fifth, you can get it in the sixth. So it can happen in any of the compartments. And because it's on the dorsal hand, you'll see it, right? There's not anything between those tendons and the skin, and so you'll see it if you look. Tendonosis, a little tougher thing to treat, or a lot tougher thing to treat. Maybe a little tougher for me to establish work as the cause, although not always. Sometimes you can really point to an obvious source. I had a gentleman who came in, and his job was scraping the inside of a combustion chamber every day, and he started to develop some tendinosis over time. And it was like, well, yeah, that probably is not something that somebody should be doing every single day forever. The MRI here has several findings, but you can see a little bit of tendonitis around this ECU tendon. So this is the ulnar head, this is the radius. You can see a little tendonitis that's swelling around the tendon, but then you're seeing some actual tearing within the tendon too. Those little white things there shouldn't necessarily be there. So some actually tendinosis and some tendonitis here. There's a little bit of inflammation around the ulnar head too, but really we're looking at that tearing within the tendon. This takes a lot longer. This takes a lot longer to fix and a lot of education. There are a lot of issues with tendinosis in the upper extremity. We do see it in the hand and wrist, maybe a little bit more common around the elbow. I'm not going to go into that because I'll be stepping on Dr. McCarron's toes. But tennis and golfer's elbow, obviously very common, and it's a tendinosis. It's a tendinopathy problem. Trigger finger actually could even be a tendinosis, and so you can actually see in some people some tearing within the tendons when you go to surgery, and that also takes up space, right? So you have some tearing, your body goes in to try and heal it, and it makes the whole mechanism bigger, and it doesn't pass nicely through that nice tight tunnel that formed around the tendon when you were growing, and so trigger fingers probably could actually be a tendinosis as well. And then this is the ECU. And so this one actually we see a fair amount in overuse injuries of the upper extremity. ECU tendonitis can be a bear. It can be really hard to deal with. And so this one I spend a whole lot of time on education. In fact, all tendinosis problems, really education is probably the most important thing you can do for somebody. You want to get them a splint and try and protect them, maybe modify their activities again, but educating about what their problem is so that they know what they're dealing with and how long it can sometimes take for people to get better. You need to get buy-in from the patient about how long it can take to get better from tendinosis, because it's not a quick fix. Sometimes surgery, sometimes, but I think in general try to avoid surgery for tendinosis problems, because you have to keep in mind what you're trying to fix, and surgery doesn't necessarily fix an intrinsic health problem with the tendon. Always education. Arthritis and synovitis. So this is a challenge for me with workman's compensation, and maybe it's a problem with my nomenclature. I talked to you about synovitis versus arthritis a minute ago, and in the workman's compensation system, the nomenclature gets a little bit hairy. So synovitis in workman's compensation essentially is arthritis. And so it confused me at first when I first started treating people for workman's compensation injuries who had synovitis, and they would say, so this is arthritis. I say, no, they don't have any cartilage wear. They don't have that problem. They just have a lot of inflammation within the joint. Oh, so it's arthritis. I'm not going to ask anybody to change the way that we all talk about arthritis. I think we have a good communication system. This is more just for how, when things get down the line with the workman's compensation claim, how you end up having to kind of clarify as you're maybe talking with attorneys or whoever else is involved. But for arthritis, you need to understand that actually you can have arthritis be a workman's compensation claim. Certainly not the most common thing, but it depends on the laws in your state. And so we obviously sit on the fence here. We have a lot of us have two different states that we deal with these cases in, and this is part of where it really becomes important to know the rules in your state. So in Washington, you can have aggravation of a pre-existing injury that is attributable to work. Basically, if you have arthritis and you fell down, then it's a compensable claim. If you have a pre-existing impairment or progression that's independent of the work, then it's not attributable to the work. So obviously if you fell down at home. But I feel like this does leave a lot of gray area. So if you have a pretty severe case of arthritis and you bang your wrist on the desk and you say that it's a workplace claim in Washington, you probably can get that to go as a workplace claim. It may take a little bit of work, but people can do it. And so I feel like it's maybe it's more black and white, but I feel like it's a lot of gray area for me. It's you can look at this and say, gosh, that arthritis really isn't because of your work. Maybe a little bit of the discomfort that you're having now is, but in Washington, you can actually make that a claim. But whereas in Oregon, it's maybe for me it's a little bit more straightforward. It's just a combined condition. Basically, you have the arthritis, you had an injury at work. You have a combined condition, so there's some portion of it that is maybe due to the workplace. I don't want to harp on this stuff too much. And I knew this was going to become a little bit more work comp talk than necessarily you guys were looking for, but my point here is that it's important just to kind of know the system you're working in. And for hand and wrist, a lot of the hand and overuse injuries do end up becoming workplace claims. And so it's good to kind of have just a base knowledge of kind of what you're dealing with. So just a couple more words on this, just to kind of clarify a little bit. In Washington, an injury just needs to be a cause of the problem that you're dealing with. And so it doesn't have to be the only cause or the main cause. It needs to be a cause. And so it could be one of even several causes and still be a compensable claim. And you can have pre-existing conditions. That doesn't change that. So if you are at work at Adidas and I guess that would be in Oregon, but if you basically play basketball at work and fall down and hurt yourself, you can make that a claim. Whereas in Oregon, the system is different. The injury has to occur basically in the course of your employment, normal employment, and it has to be For an injury, so for a fall, a broken arm, that sort of thing, it has to be a material cause, so substantial but maybe not the only cause. There's actually a higher degree of causation that's involved with something like an overuse injury. So with an overuse injury or an occupational disease, you have to have, it has to be the major contributing cause. So this is really what I wanted to talk about today, and a lot of that other stuff is just kind of background. How I like to handle workman's compensation and how I like to handle maybe more appropriately return to work. I am kind of harping on the workman's compensation again because this isn't a challenge to get people who don't have an active claim back to work. Most people are kind of pushing me. And so when I'm working to get somebody better and back to work, it's super important to set expectations from the get-go. Starting right off the bat, setting expectations is probably one of the most important things, if not the most important thing. I didn't do this when I was first starting out, setting a clear plan. I think looking back at what I used to do, my plans were wishy-washy. I'd say, oh, we could do this, we could do that, and that's just makes everything muddy and it does not work well. And so you want to set a really clear plan. You can deviate from the plan later, but set your plan and try and go with it with variations if need be. This is obviously super important. I've been kind of touching on this briefly, but you've got to engage people in their own healthcare, more so with this than a lot of other things. They have to be involved in this. They have to be bought into the idea that they are going to get back to work, that they are going to have to maybe do some things that will get them to be feeling better. And then setting some realistic goals. And goals and expectations, I think, are different. For me, the expectations, it's kind of me being dictating to them almost, and I feel bad. It's almost paternalistic, but you have to kind of get it out there that these are my expectations of you. This is what I expect. Whereas the goals is kind of what they want to hear, right? So you're setting some goals. We're going to do this, and we're going to get this done, and we're going to get you feeling better, and that sort of thing. So we'll go through more of this. Starting early. Start the very first visit when somebody comes in, with carpal tunnel, with your trigger finger, with whatever it is. I expect you to continue working. Okay, this is not something that's going to put you out of work. I expect you'll continue. We may have to modify things a little bit. We may have to protect you a little bit, but I expect you to continue working. And that's not always the case, right? So there are certain things where people come in and say, I expect that you are not going to be able to work until this time. It's important for me, and it's going to be a different discussion for you guys, but for me, when you are talking about surgery, I expect you will be off for 10 days or thereabouts. It can vary, but try to kind of set a plan, set an expectation for somebody early on. I think that you're going to probably need surgery for this problem. We need to get your nerve test done, and then once we have that nerve test, and I do suspect you have carpal tunnel syndrome, we're going to discuss the results of the nerve test, and then we are going to most likely do a small surgery that will help you, and I expect that you'll be off of your employment for 10 days, and then you'll return to work in your normal capacity, or you'll return to work in a light duty capacity. I don't expect you to be on narcotics. You have to address the narcotic issue, right? You have to hit that one head on. You'll be done with your visit. You guys all know this. You'll be done with your visit, and people come in and say, "Oh, it's really hurting. Can I have some blank?" And if you tackle it head on, if you try and kind of just disappear and say, "Oh, I'm not there. I don't want to hear it," it doesn't work. And so you gotta talk about the narcotics, And so setting that expectation at the very beginning, you will get some pain medicine after surgery to take care of your pain for the first 5 days after surgery, and then we'll switch you to Tylenol and Advil or whatever's appropriate. But you're not going to have narcotics before surgery, I think, is an important thing to say. It's a challenge, understanding job requirements, but in your setting of expectations for people, you really kind of need to understand what they do for best you can for work, and you get a very different view of that when you talk to the patient versus the employer sometimes. But getting your head wrapped around what they do for employment can really help you with setting expectations. So it's for me, I would expect to be off of work through the weekend for a carpal tunnel release, whereas, if my job was jackhammering, I would probably expect to be off a little bit longer. And so understanding their job requirements is going to help you to kind of set these expectations and help them set these expectations. When I say be as consistent as you can, what I really mean is not necessarily for that single patient, but across people. So for office type work, I tell people after surgery that I expect that you will be off work for up to 10 days, right? And I try not to deviate from that too much, because as soon as I start telling this person 14 days and that person 9, it gets confusing. It gets confusing, and then I kind of screw things up, and somebody says, wait, you told me it was going to be 14 days. And so I try and kind of set that expectation for them early and be consistent across types of employment. Again, I've said this multiple times, get them back to work as soon as you possibly can. Hopefully the first day. Don't ever take them off if you can avoid it. And there's a lot of things out here that it's not dangerous for people to return to work. It may be uncomfortable, but it's not dangerous. And so try and get some buy-in on that and have them working, even if it's in a modified capacity from the get-go. And then reinforce those expectations each visit. It's not that you have to talk about every one of these things each time, but when it seems appropriate, make sure that you kind of say, I expect you're not going to need those narcotics. So setting a clear plan. Be honest about your opinion of the causation of the injury. If you think it's not work-related, tell them it's not work-related. It doesn't help anybody if they go on thinking it is when it really isn't. And vice versa, Some people come in, and this doesn't happen very often, but some people come in and will say, I had this happen, this happened, this happened. I say, oh boy, this probably actually is a workplace thing, and so you should probably go into a different system. That doesn't happen too often, but occasionally it does. I like to use phrases like, what we should do to help you. So again, trying to get buy-in, trying to get them involved in their own care and to understand that that they need to be a part of this. And so what we should do to help you. We should get this nerve test. To help you, we should do an injection into your hand. I know you don't want an injection. I know that you're concerned about the injection. I know that it may hurt for a minute, but it will help you a lot. Make sure that you repeat your plan through the visit once or twice. We all know, we've all heard that people only remember a couple things from their visit, and if there's an important part of your plan that you really want somebody to remember, repeat it. Make sure that they remember it as much as you can. And then I actually had this happen yesterday. I had a guy in the office, and I kind of repeated myself a couple times asking if he had questions, because I could tell there was something on his mind. You can tell, obviously. I said, you have questions? And finally, I think he just got tired of me asking if he had questions, and he was like, no, I'm done. He got up and just walked out the door. All right, I guess we're good. Empowering the patient. I think we all try to do this, right? This is more getting them to buy in, and I find it to be super important for overuse injuries in the workplace, because some of them can really linger. And so they need to have some homework, things that they can do to help themselves. And so whatever that is, whether that's with a tendonitis problem, trying to change this activity and this activity, or if it's wearing that splint that they actually do need, it's super important. And I guess that ties into this one here, asking for their help. Part of their homework will be, it's not clear to me why the lateral side of your elbow is numb when you have carpal tunnel syndrome. It doesn't really fit with your anatomy, but I want you to pay particular attention to, whether this finger or this finger or this finger is causing you problems. And tell me, are you getting pain in the forearm? I want you to really you don't have to write it down necessarily, but if you want to, you can. I want you to keep a little kind of mental note or a diary about exactly where you're feeling this. And that really helps clarify things for me sometimes, because sometimes people come in and say, my whole arm's numb. You say, well, is it? because that's a different problem. That's probably not carpal tunnel. And so getting them to buy in and do their homework on this, I think is really helpful, because it really makes it clear to them what the problem is. Use your splint. And I'll have them, when it's somebody who I think is probably not really going to want to use the splint, that splint that you handed them, I'll say, I want you to wear this for 2 weeks, and I want you to call me. And I want you to leave my assistant a message. We don't have to talk, but I want you to leave her a message. And I expect that message in 2 weeks about how it's been. Right? It's a little thing, and it takes no extra time really, and it's a huge amount of buy-in from them on using their splints or whatever it is, because they now know that I'm checking up on them, right? It's like when we send people to therapy sometimes. Sometimes I'll send people to therapy because I just want them to know that I'm watching, right? It sounds a little creepy, but I'll oftentimes talk to people about running a marathon on their hands. And so when you've got an injured extremity and it's your ankle, it's kind of easy to know that you're not supposed to run a marathon, right? When you sprain your ankle, you're not going to go out and run a marathon. But we still expect that on our hands we're going to keep running that marathon, right? Keep using your hands injured. It's the way that you explore the world, and you're not going to stop that. And so your expectations need to change a little bit if you're injured. You need to understand that you can't run that marathon on your hands. We're getting there. I'm almost done. So setting some goals. Make sure, whether you think you can get there or not, make sure that they understand that your goal is to get them back to 100%. I don't think there's a huge harm in saying that my goal is to get you back to 100%. I'll qualify that. I'll say, I want to get you back to 100%. I don't think I can do exactly that. I think that you may have some residual issue with this arm after we're done, but I'm still going to shoot for 100%, right? This is what they want to hear, and it's important. If you don't kind of end up with some of this stuff, they're not going to be very happy, and they're not going to get that buy-in. Give some realistic time frames as to what you expect. You're probably going to be wrong, right? Much of the time. But give it some realistic time frames. Say, I expect that this is going to take 2 weeks. This is, going to take 6 weeks. You'll be back doing this and this and this in 3 months or 4 months or whatever you think it may be. And if you're wrong, you're wrong. And they can be mad at you about your timing of things. And you need to have a thick skin. If you don't have a thick skin, you're probably in the wrong line of work. And so, you can be wrong sometimes, and it's okay. But giving them some realistic thing to shoot for, I think, is super important. Setting some milestones, that kind of goes hand in hand, right? So as you're talking about the time frame for things, you want to set those milestones. We're expecting you to get, to this, and then to this, and then to this. When you have that surgery, you're going to have some scar tissue that develops over the course of the next 6 to 8 weeks. It's going to be a little bit tender while that's happening. Your body's very metabolically active in that process, and so there's some inflammation. It hurts, but that will go away. And so setting these milestones and realistic time frame for things, for me, for surgery, it's pretty important to do, but it's equally important for you guys to kind of keep them on the right time frame. And then there's no light duty. Sometimes there's not, but I think it's good to, even if the person tells you that there's no light duty, to get them back to doing something if they can. And so put them onto a light duty program if you think that's the most that they can do. Make it a goal that they get immediately back to light duty. Our goal is to get you immediately working in some capacity. And if your employer says there's no light duty, and then they'll tell you to stay home. But we want you to work in this capacity for this period of time, and our goal is to get you back in 2 months to full employment. So why is this important? Because look at the difference and this data isn't pure, right? So this is neck, back, and upper extremity. But it's super, super expensive when you look at upper extremity and neck and back claims in the workplace. Obviously, this is not in dollars, but it's closing in on half of the time loss is upper extremity and neck and back issues. It's super, super important that we kind of figure out how we want to handle this stuff and maybe do a better job of it, because there's long-term, as we all know, there's a lot of people who have these workplace issues of overuse, and it's a huge drain on our workforce. And so we want to figure out a way to make this work better, and it starts, honestly, with you guys. So what we discussed, this was the most important talk of the day. We talked a little bit about some terminology, carpal tunnel, cubital tunnel, tendonitis, those sorts of things. How important it is to kind of know a little bit about the rules that you're kind of dealing in, and then how I personally like to handle an interaction with a patient in the workplace. And then setting your goals. You can stick to it as much as you can, but there's going to be some wiggle room. Remember that going back to work or treating people who need to go back to work after overuse injuries or any injury in the workplace can be really rewarding. This obviously is not an overuse injury. This was a carpenter who lost a couple of digits. But he had absolutely the right attitude about this thing. He was wanting to get back to work from day one. He was just that kind of guy, super positive attitude, maybe a little bit confused. He kept telling people that he was just going to walk around now, tell them to hang loose. And I told him, I actually didn't have the heart to tell him that we'd have to cut off his index finger to actually make that true. So anyway, thanks.